Good morning, thank you very much. Obviously, the aortic arch is not really the environment for us as vascular surgeons, but it becomes more and more a territory where vascular and cardiac surgeons meet each other, trying to find solutions different than the standard open procedures. Some words on acute type A dissection, about incidence 2 to 4 per 100,000 per year. Surgical mortality has improved over the years and dropped, but still is around 18% in experienced hands. And those who are unfit for surgery are in a bad shape, obviously. If we look at the management, this is a large study in a German registry. The 30-day mortality is really improving in the younger aged group, but for patients above 80 years, the prognosis is much less positive, and these are at present the candidates for endovascular exclusion of the problem. I will touch on that in a second. In open repair, and for those who have experience in that, there are some critical issues, because clamping is a problem in the very, very vulnerable aortic wall. Sewing is a problem, bleeding, cannulation, and obviously it's even worse in connective tissue disease patients. So it's really damage control surgery in a sense. There are some associated issues, of course, because you have the acute type A dissection, but also the chronic type A dissection, which is easier to handle. However, it's not only dissection, it can be associated with aneurysm, root involvement, aortic valve, the coronary arteries, and this all makes the procedures very complex in the most extensive forms. What you see in literature is that in the current era of hybrid and endovascular aortic technology, the surgery is more extensive than ever before in preparation of endovascular extension of the pathology. So what I also see in our group is that in the past, the dissection was only treated by a small supracoronary, for example, interposition graft, is now replaced, if the tear extends in the arch, by complete arch repair and a frozen elephant trunk. So there are several options, like in this case with the debranching, if you have an adequate ascending aorta and the arch dissection in the middle, where the part is covered with an endograft, or this traditional ascending arch repair with a traditional elephant trunk and then extension by endovascular means, or, which is more common nowadays, the frozen elephant trunk technique, which is a very neat operation, of course, and extension, if necessary, down to the abdominal aorta. So the question, what will be in the future? Is it going to be endovascular or open surgery? And these questions in literature are, of course, very relevant. We have the materials, but do we have the courage to do it? And more groups are focusing on endovascular repair of aortic dissection in the ascending and the arch, but technically it can be very, very dangerous, obviously. So if we look in the literature, how many patients would be candidates for endovascular solutions in acute arch or ascending dissection? Hypothetically, on very well-performed studies, it's around 18 to 20%, which of course is a limited number, but you have to start somewhere, obviously. And the main reasons for unsuitable endovascular repair are a poor proximal landing zone, entry tear being in zone OA, so very close to the coronaries, an inadequate distal landing zone, and the dissected supraaortic arteries. So what would be the technology be? It could be the approach with a small anterolateral thoracotomy with a purse string on the apex of the ventricle, and that would be the introduction site for the endograft. There would be a guide wire coming from the axillary artery in this position, and then the endograft could be introduced for example, the TAVIs were performed in the very early phase of TAVI implantation. And then the endograft is positioned where it has to be, of course, to cover the entry tear. And here the limitations, of course, are the coronaries, and if the aortic valve is affected, the valve and the root as well. But technically, we are step by step getting there, where the endograft will be positioned covering the entry tear, and then a second endograft with the typical fenestrations for the coronaries, and if necessary, followed by a valve implantation. So this is theory. It has been tried in animal experiments. Some patients have been treated like this, and if it works, it would obviously be a fantastic solution in the future. So some considerations in the treatment of type A dissection. In connective tissue disease, the modern approach is maximal repair, so ascending arch repair and frozen elephant trunk in the majority of cases. In general, if the root has to be replaced, it has to be done, otherwise you have to come back a couple of weeks or months later. Exclude the false lumen perfusion, as discussed in the previous talks. Resect all the dissected aortic wall tissue, that is the prerequisite. Restore malperfusion, which is a clear argument. And this is the most important part for the future, anticipate on secondary endovascular procedures by giving a good landing zone for an endograft. And of course, we are waiting for further innovation in endovascular devices. Thank you very much.